for inviting me along. I am a nurse and a midwife by background. And today I'm going to talk a little bit about iron deficiency and iron deficiency anemia in pregnancy. So what we're going to look at today, we're going to think about what's the current situation for women in the UK. How does it affect people day to day? And what risks are they going to be exposed to as they go into that pregnancy journey? And we're also going to take a look at what can we do within our practice to raise awareness and reduce the impact and the risks of iron deficiency and iron deficiency anemia. So the numbers are quite staggering. The World Health Organization estimate about 1/3 of the global population have got anemia, and 50% of those are due to iron deficiency. Now, although we think this is most likely a problem in low and middle income countries, which it absolutely is, it's actually classed as a moderate public health risk here in the UK because it affects 1 in 4 women of childbearing age. Now, back in 2012, WHO set their global nutrition targets to decrease that number by 2025 by 50%. But sadly, we are nowhere near achieving it. Women are disproportionately affected by anemia, and the most likely and most common cause is heavy menstrual bleeding. So that's 80 mils or more per period. And it's actually the leading cause of years lived with a disability burden in women. Now, when we think about iron, we tend to think of red blood cells and hemoglobin, and rightly so, because building our red blood cells does take the lion's share of iron, but it's a really essential nutrient for lots of other functions within the body. So that includes things like DNA synthesis, neurotransmission, developing the myelin sheath that covers our nerves. It's got a role to play in immunity, and it's got a really significant role in energy production. And if we become iron deficient, it's going to affect all of these processes. But because we're prioritizing the red blood cells, hemoglobin can remain normal or normal for that person. But whilst they're becoming iron deficient, if they're not replenishing their iron stores and they become deficient, all of these other processes are going to start to be affected. So they can have symptoms way before we're seeing a low hemoglobin. Now, what does it look like? What does it feel like when people start to become iron deficient or develop anemia? So having fatigue, feeling tired, it's not just feeling a bit weary, it's really exhausting, debilitating fatigue will be really common in a lot of people. It can affect people's mood. They can have very low mood, feel quite irritable. Some people will have brain fog, have difficulty concentrating, and then you get the more sort of quirky things like craving soil and ice. Some people will have breathlessness, palpitations, or headaches and dizziness. And you can see from these symptoms, they're really broad, really, they can be really sort of non-specific, really broad, and people will often attribute these to kind of non-physical things. They will put it down to, I've got a hectic lifestyle, everything's really stressful at the moment. Could be perimenopause, or other people will just brush it off as normal for pregnancy, and they're not actually going to go looking for a physical cause. Now, if people do go and look for a physical cause, remember their hemoglobin could still be normal, but they could be iron deficient and having these symptoms. So for some people, it can take years for them to get an actual diagnosis. Along the way, they can get inappropriate treatments such as antidepressants, inhalers, and all the while it has a really significant effect on their home life, on their work life, their ability to exercise, and their ability to socialize. And it's not just without risks. So what World Health Organization studies have shown that when you've got a hemoglobin of less than 70, that's associated with double the risk of mortality for the mother. And we've got studies in the UK that support this and show that with our hemoglobin, if it's lower than 85, then it was something like 62% of the women went on to have a postpartum hemorrhage of 500 mils, and 25% of them had a blood loss of over 1,500 mils. So it's a really significant effect on women. Now, even if they don't have a postpartum hemorrhage, those who have a sort of small or moderate blood loss, if they're iron deficient or anemic, they're not going to be able to tolerate that amount of blood loss without more significant symptoms, and it puts them at increased risk of a blood transfusion. Now, for the baby, they're at risk of having a lower birth weight, having a premature birth or stillbirth. they could be born with iron deficiency anemia as an infant. So they're going to be experiencing a lot of those symptoms on the previous slide. And it's possible that they could have impaired neurological development as well. So ideally, the ideal scenario is that we can identify and treat iron deficiency or anemia early in pregnancy, or preferably before, to try and prevent some of these maternal and fetal risks and improve their quality of life. Now, once you become iron deficient or anemic in pregnancy, it's pretty much impossible to catch up with diet alone, because the demand in pregnancy for iron will outpace the nutritional input. Now, there's some red flags. Some people are going to be more at risk of iron deficiency than others. So it's good to be aware of these red flags. Now, poor nutrition. Now, that could be because it's the cost of living. They can't afford to have good nutrition. For other people, it could be that they're time poor. So they're relying heavily on processed, fast, easy, ready meals that don't have a high nutritional content. For some people, it's well-meaning life choices. If you're vegetarian or vegan, they can be very healthy diets, but it can be very difficult to get the right amount of iron from those non-heme iron sources, because we don't absorb them very well. And for some people, they won't absorb it very well because of medical conditions, for example, celiac disease, or they could have had bariatric surgery, so it's physically harder. Now, heavy menstrual bleeding, as we said earlier, that's a really significant cause. If you're losing at least 80 mils of blood 12 times a year, that's 1 litre of blood, and that equates to about 500 milligrams of iron. And if our iron stores aren't constantly being topped up, that's a sort of a long-term cumulative effect of iron loss. Now, endurance athletes, they've got a kind of double whammy, because when you're doing lots of heavy exercise, you're in an inflammatory state. And when inflammation is present, the hormone hepcidin, which controls the absorption of iron, goes up and will block iron absorption. The double whammy for them is that we don't lose iron in many ways. Blood is one, sweat is another. And if they're constantly doing lots of exercise and sweating a lot, they're actually losing a lot of iron as well. So other inflammatory medical conditions are going to put people at risk because that hepcidin goes up, and obesity falls into that camp as well, because obesity is an inflammatory condition, so they may have a high hepcidin. Now, there's quite a few obstetric reasons as well. So if you've had very close interval of pregnancies, you won't have had time to replenish your iron stores. So that's less than a year since last pregnancy. Or if you've had 3 previous births or more, it's the same effect of depleting your iron stores. And if you've got twins or more in this pregnancy, you've got a huge, huge demand for iron on that pregnancy. So people with these red flags, it's worth thinking about checking their serum ferritin to look at their iron stores, because some people it might be worth considering starting them on oral iron prophylactically. Now, when we think about the hemoglobin thresholds, now these were based on quite old studies by the World Health Organization, 6 small studies, mainly white Europeans and North Americans, very few pregnant people, nobody had a ferritin level measured. So they were reviewed, and last year, I think it was April 24, they republished their guidance. It's not hugely changed. So for non-pregnant women, hemoglobin threshold is 120. First trimester, it's 110. And then as you go into the second trimester, it's 105. Now, I've got up here the Society for Hematology guidelines, and they keep the hemoglobin at 105 for second and third trimester. Now, the reason we've got these lower thresholds in pregnancy is because right from the first trimester, we increase our blood volume by a minimum of 40%, in some cases up to 100%. So you've got much more blood volume circulating, but it's not all red blood cells. It's a huge volume of plasma. So you get this hemodilution effect. So the NICE guidelines are recommending we do full blood counts at booking at 28 weeks, and then for people with multiple pregnancies, 20 to 24 weeks. Now, studies in the UK show about 30% of women antenatally will have anemia, and then postnatally it varies between 20 to 40%, depending on the studies you're looking at. But of course, hemoglobin doesn't tell us the whole story. So anemia, it's the end result of iron deficiency. So the symptoms can start way before they breach these hemoglobin thresholds. And when we think about serum ferritin, so that sort of measure of iron stores, Ferritin is increased in inflammatory conditions, and pregnancy is an inflammatory state. So the cutoff for serum ferritin in pregnancy is 30. Although people can be symptomatic, ferritin of less than 50, and all the thresholds are constantly being questioned because in pregnancy things aren't quite as reliable as we might hope. And so if we're going to prevent iron deficiency anemia, there's certain things we need to think about. Everyone should understand healthy eating and the things that can influence iron absorption. And it's really important that women know of what the signs and symptoms are, because if they can recognize they might be iron deficient or anemic and report that, it gives us more time to get on top of it early and hopefully correct that anemia before they go into labor. So the advice would be you want to eat more of your heavy iron-based foods, and it comes in two forms. You've got heme iron and non-heme iron. Now the heme iron, that's our animal-based iron. So you're looking at meat, poultry, and oily fish such as salmon, sardines, and mackerel. Now this type of iron, we can absorb about 30% of the iron from that food. And the other way we get it is from our non-heme sources. Now, that's our plant-based food. So you're looking at dark green leafy veg, all of your pulses, so any kind of bean, lentil, and chickpeas. Tofu is a good source. Nuts and seeds and dried fruit is another good source. Anybody who likes chocolate, you'll be pleased to know dark chocolate is a really good source of iron. One of those sort of 100 milligram bars will give you up to 11 milligrams of iron. Now, I'm not recommending you eat the whole bar, but if you do, chances are you'll get a good dollop of iron. That said, with the non-heme sources, we only absorb between 1 to 10% of the iron. It's harder for our bodies to process. So some things that can help with absorption is to avoid tea and coffee an hour before and an hour after meals. The tannins in there can interfere with iron absorption. And if you have vitamin C with your meals, that can help absorption. So any kind of fruit and vegetables or fresh orange juice high in vitamin C can make a difference to what you absorb. Now, it's helpful to have a little overview of iron metabolism if we're going to think about treating. In that top left corner, I can see on my slides a little image of a stomach, but it seems to disappear on the main slide, so just visualize a stomach there. So every day, from that dietary intake, we're looking at absorbing 1 to 2 milligrams of iron. It comes from there and from the iron that we are recycling in the body. Now, that absorption is controlled by the hormone hepcidin, which is produced in the liver. Now, hepcidin, when it goes up, it will block iron absorption. So situations where you've got inflammation, some studies show the first trimester of pregnancy it goes up, but then it drops drastically in the second and third. Or if we've got high circulating iron, hepcidin will go up and it'll stop us absorbing more. It's protective. It will go down if we're iron deficient, if we're hypoxic, or if we're actively bleeding. So it will drop and allow us to absorb iron. Now, the hepcidin controls ferroportin, which takes that iron to plasma where it's bound to transfer in. Now, iron's one of those nutrients. It's got a very narrow margin between being beneficial and being harmful. So if iron is not bound, it can produce free radicals, and free radicals are harmful to DNA synthesis. So it's bound to transfer in where it's taken to all of the organs and tissues where it's needed. And what you can see from the slide there, the lion's share does go to the red blood cell production. Now, when they reach the end of their life cycle, you've got another 600 milligrams tied up there. We contain a similar amount in our muscle and bone, and another large amount is contained in the liver. Now, we don't lose a lot of iron every day. It's lost mainly through blood loss, through sweat and shedding of skin cells and mucosal cells. So when we think about treating iron deficiency or anemia in pregnancy, it's really not very well supported by research. Optimum doses aren't really identified. We know that the hepcidin, when we've got high iron present, hepcidin will peak for about 48 hours. But if you identify anemia, then the thing you want to get on top of is to start a trial of oral iron for 2 weeks. Now, what that would look like, so it's recommended people have sort of 40 to 80 milligrams of elemental iron. You would find that in, for example, ferrous sulfate 200 milligrams. And it varies. Some people would recommend you have it once a day, and you would take that oral iron once a day in the morning because hepcidin is at its lowest in the morning. Take it with no other food and drink other than water or some orange juice, and to have no other medications or multivitamins at the same time because they might interfere with the absorption. You would be hoping, and you're going to continue that for at least 3 months or until 6 weeks postpartum. You would be hoping to see an increase in hemoglobin of 10 within 2 to 4 weeks. So you need a process in place to follow it up and make sure it's being effective. Now, some people do get a lot of side effects and can't tolerate it very well. And so for them, taking it alternate daily would be helpful, because when you have that oral load of iron, your hepcidin goes up, stops you absorbing more. And if you keep piling more on top, you won't get any more of a therapeutic effect, but you will get the side effects increased of constipation, diarrhea, bloating. Now, the situations where you're going to want to think about escalating care beyond midwifery services. So if the hemoglobin is very low, below 70, you would escalate. If someone's got significant symptoms, if someone is more than 34 weeks, we just might not have enough time to get their hemoglobin up to a sufficient level before labour. Or if their hemoglobin's not responding within 2 to 3 weeks, you want to escalate. And you'd also want to think about looking at their B12 and their folate, because those are the other building blocks of blood, and that might need to be addressed. So the next step up from oral iron would be IV iron. That needs to be given in a clinical setting where you've got staff trained for anaphylaxis. And you would consider IV iron from the second trimester onwards for people that are unable to tolerate oral iron, or people who are not responding, or that you simply don't have enough time, so 34 weeks or more, or if you've got severe symptoms. Now, you wouldn't want to give it in the first trimester because you're getting a big bolus dose of IV iron, and you've got that increased possibility of unbound iron and free radicals and the potential harm and effect on DNA. Now, you also would want to think about whether there's bacterial infection present, because bacteria thrives quite happily in a high iron world. But there are some studies that suggest Ferinject and Monifer have got a decreased risk. So blood transfusion, when might blood transfusion be appropriate? Well, there are some situations. If someone's got some severe, significant active bleeding, that is the time and the place. If somebody has a hemoglobin less than 70 with severe symptoms, that might be the situation when they might need a blood transfusion. But if we are going to give a blood transfusion, you need to bear in mind you're only actually getting 200 milligrams of iron in that unit. So you still need to think about completely repleting and replenishing those iron stores. If someone has a blood transfusion, you need to think about a restrictive transfusion policy. So this would apply to a stable adult without significant bleeding. And that would entail giving 1 unit of blood, rechecking their hemoglobin, and doing a full clinical reassessment to see if any further units are needed. Now, you might wonder, with all these risks, why don't we just give oral iron to all pregnant women? And it's simply because there's not enough evidence to support it. So live at the moment is the PANDA trial. I always trip over this. It's the primary prevention of maternal anemia to avoid preterm delivery and other adverse outcomes. It's live, they're actively recruiting, and they are looking, it's a randomized controlled trial, 2 groups of non-anemic women. One will be having ferrous sulfate once a day, the other will be having a placebo. And you can see all of those primary outcomes there that they're looking at. But they are also looking at, observing for gestational diabetes, gestational hypertension and infections, because some studies indicate that can be a risk in pregnancy. So I think the slide's going to be available, so you can hop on the QR code and have a look at that. So thinking about care in labour. So the mode and the timing of delivery is not affected by anemia. The location is. So if you have a hemoglobin of less than 100, then a hospital setting is recommended for birth. You've got that increased risk of postpartum hemorrhage. And it's also worth considering citing an IV cannula for people at risk, and taking group and save, because if you did need to go down the route of a blood transfusion, you would want a group and save that's been taken within the last 3 days or as close to the event as possible. You'd also want to think about active management of the third stage to minimise the blood loss. Now, if your hospital offers cell salvage, that's definitely something to think about if you're having if you're having a cesarean section, especially if you've got other risk factors for hemorrhage. Now, if the woman is D negative, then you would look to do, if she is reinfused with that salvaged blood, you'd look to do the Clyhara within 30 to 40 minutes after reinfusion, and she would have her sort of standard 1,500 units of anti-D. It's worth noting on the Clyhara that she's had salvaged blood just to really alert the lab, so you get the right dose. Further doses might be needed depending on the fetal maternal hemorrhage results that come back. Now, tranexamic acid is definitely worth considering. Now, it inhibits the breakdown of fibrinogen and fibrin, so it stops blood clots from breaking down, and you'd use it early into a postpartum hemorrhage. So the woman trial found that people who had a PPH within 3 hours of birth, if they were given tranexamic acid, it did significantly reduce the risk of death by bleeding. And the Embrace report that's just come out, this latest report, 7% of deaths were due to obstetric hemorrhage. And you would give it alongside the usual uterotonics. Now, although it doesn't break down blood clots, that's its job, to not break them, to not let them break down. It does not increase the risk of venous thromboembolism. Now, the Woman 2 trial has finished. They were looking at giving tranexamic acid prophylactically to women with moderate to severe anemia. And the intervention was to give TXA, tranexamic acid, when the cord is clamped to see if it could prevent a postpartum hemorrhage. Unfortunately, it didn't. So it's not effective. And then rounding up to our postpartum folk. So if somebody has had unresolved anemia antenatally, if they've got symptoms of anemia, or if they've had an estimated blood loss of 500 ml or more, you're going to want to look to do a hemoglobin around 48 hours. If they need treatment, it would be having oral iron up to 3 months postpartum. If they've got severe symptoms, look at IV iron. And just to reiterate that transfusion's not indicated if the hemoglobin is more than 70, unless you've got a really significant risk of bleeding or cardiac compromise. Now, I've included on this just the 3 main guidelines that you would use. There's also an obstetric anemia toolkit on the NHS Blood and Transplant Hospital and Science website, so it's got lots of resources. And that concludes my presentation. Happy to take any questions.